I treat non-muscle-invasive bladder cancer regularly, a little less muscle-invasive as compared to Dr. Basu. And so it's generally a big overview of topics here. I don't know where you all come from. There's certainly a little bit of science in here, some history, some research, some engineering, but by and large, it's an information-based topic of non-muscle-invasive bladder cancer. So I do encourage you to ask your questions. I'm happy to take them. Medical information is no substitute for having a doctor. And this is not your doctor, recognizing my patients here at least. But I'm certainly happy to take your questions and try and help as I can. So with that little introduction, so there's a few slides in here that are probably a little bit busy, so if you can't see everything, don't worry too much. But please go read as it goes on. So this is my conflict of interest. I do have some funding from AstraZeneca, Health Research, Bladder Cancer Canada, it's not on their Cancer Research Society, and then a consultant for different companies for various reasons. But none of that is what I'm saying today. So I was hoping to talk about non-muscle-invasive bladder cancer. I'll be particularly talking about some of the current treatments. I will go into some of the potential new treatments that are coming. These are not things that are used yet. And of course, we'll go over some questions. So this I took from the website. Again, you might have heard this before, but it is very common. It does affect men much more commonly than women. We don't know why. But I was interested in that, obviously. And it is quite common overall, affecting mostly elderly people, but it's true. I definitely see it young women in my practice as well. And so this is there's two things in cancer that we always talk about as physicians. It's the grade and the stage. So the stage meaning how far has it evolved? So is it something, and there's different sort of levels of that. Is it something that's locally advanced, or is it something that's spread elsewhere? This is all to do with stage. This picture here shows you the local staging, that is we call T staging in the jingo that we talk about. And this is, as the name implies, is largely based on whether it invades the bladder wall. And so we have TIS, TA, T1. These are all considered non-muscle-invasive bladder cancer. That is to say, it's non-invading the muscle. We say NMIBC because it's a mouthful sometimes. They're going to hear more about muscle-invasive bladder cancer. So, and this is assessed, the tumor, which we'll talk about in a few slides. But this is sort of where we get the term non-muscle-invasive bladder cancer. What's curious about bladder cancer compared to other cancers is the CIS category, or TIS. It's the same thing. What it stands for is personal in situ. And what this is to say is that it's cancer that is flat. It doesn't go in at all to the surface, and it's flat. What's a bit different here is that that's actually worse than TA disease, which is slightly invasive. T1 disease invades what we call the lamina propria, which is sort of the first layer of the bladder before it gets to the muscle. And so the TA-T1 and CIS are grouped together are considered non-muscle-invasive bladder cancer. And so that's to do with the staging. Staging also, as I mentioned, does have to do with whether you have something elsewhere in the body, like the lung or something like that. But that for non-muscle-invasive bladder cancer is almost everything. So it's really just what we call the T staging, the local staging, which is important. So that's one important concept. We talk about what kind of cancer have I been diagnosed with. It's what is the stage of cancer, and this again based on the removal of the tumor at surgery. You can't tell this by just looking at it. Usually you have some idea, but you really need the pathologist to make the diagnosis. The other big thing about classifying bladder cancers and cancers in general is to do with what we call the grade of cancer. And this is not the same as stage at all. What this is you hand the tumor to the pathologist, they look at it in the microscope, and they say, this doesn't look that bad. It doesn't look that aggressive. It doesn't look like the cells are dividing rapidly. This is a lower grade tumor. Or they look at it and they say, this is very aggressive. This tumor is rapidly dividing. The cells are multiplying fast, and they can sort of see this by looking at it, which is why they're experts, because you and I look at that and it's a bunch of cells at most. So that's how they divide it. Low grade, high grade disease. There's something that's called lung papillary neoplasia of low malignant potential. This essentially is polyps. It's nothing per se cancerous, so it doesn't technically classify, although it's a bit controversial, as bladder cancer itself. It's actually fairly rare, but not uncommon. And so this is the main diagnosis. There's another stage you may hear of 1, 2, and 3, but it dates to 1972, which is before my time. And so everybody basically uses low-grade and high-grade disease. And this is very important in the treatment decisions, particularly for everything that's considered non-muscle-invasive bladder cancer. So this is the stage and the grade, and these are the two, if I could leave two things to take away to understand more than half of how we deal with bladder cancer, it's really the stage and the grade of the important decision points for management. And again, how it looks in the microscope is how it's done. So the rest of the talk is really getting into treatment. How do we manage, how do we treat bladder cancer in 2023? I'm going to talk about intravesical treatments. What is BCG? Go into that a bit. We'll talk about chemotherapy treatments inside the bladder, I should say, the intravesical. It means inside the bladder. It means something that we translate into English. So, and then we'll talk about surgery as well, because it's essentially where every patient journey starts. After cystoscopy, we look in the bladder. The next step is surgery. And so I'm going to start with that here too as well, since I'm a surgeon. And there's really two surgeries, and there's variations on theme here for some of them, but there's really two main surgeries that are done. What we call TURBT, or transurethral resection of bladder tumor. This is the surgery where we look inside with our camera. You're asleep or you're under spinal anesthesia, and we scrape out the tumor. And this is the main surgery that we do for bladder cancer. There is another surgery that has more to do with muscle-invasive disease. It's almost never, but there are always rare exceptions in medicine, used for non-muscle-invasive disease. And so how does this fit? So this is surgery where the tumor is scraped out the bladder. It's typically done as day surgery now. When I trained Toronto, I guess more than 10 years ago now, we would admit our patients overnight, but I would say in our institution, the CHU de Quebec, we do that almost always. Patients are able to go home the same day. The surgery itself is variable in length. Some very little small tumors that only once you're asleep and we're all ready to go, it takes 5-10 minutes to do. Other tumors are larger, other things are more complex. So it's variable. Some surgeries take 40 minutes and others take 30 minutes. It's pretty rare that it takes more than an hour, but that's of course happened. And this is where we remove the tumor to get the grade and stage by brilliant pathologists who help us out. So this is a picture that I took off the web, of the radiologist website, I think. This is a picture of a tumor. You can sort of see the growth here. That's a tumor on the background of the bladder, and of course go in through natural orifices to do so. And TURBT, generally speaking, we do this when you're asleep. Sometimes fine. So just a few words about recovery after this. It's a common operation. Recovery time does vary. Sort of the usual factors in medicine, how healthy you are, if you have other complicating factors, if it's a very big surgery, your age overall, this impacts things. Most of my patients, I tell them that basically, you get back to normal in about a month. There are patients that it takes longer. There are patients that go back to work in a week, but most people it takes a bit more than that. It does happen that after the surgery, for various reasons, whether it's complex surgery, whether it's concerns about bleeding, whether there's scraping went a little too deep through the bladder, which is one of the risks, we leave a catheter in. And this is mostly for safety, and that can be left in for sometimes a day, sometimes a week. It depends a bit on our judgment at the time of surgery. That decision is usually made at the surgery. We can't really sometimes we know in advance that it won't work and we need to leave the catheter in. Sometimes we are optimistic that we won't have to, but it's always final decision happens at surgery. And so in terms of instructions, I think pretty much every hospital has some sort of instructions to give you when you leave regarding how things go. I just had this slide in last night, but it's just sort of an example of some post-operative instructions that we would give. When can I go back to normal activities? Well, it depends how you feel. If you're not feeling great, then take things slower. But basically, my message to my patients is progress as to how you feel. There's no real restriction in the sense that if we don't want you to lift something really heavy and strain a lot and have sort of the scab and the bladder fall off and it bleeds, it's pretty rare. But it is good to walk around. It is good to move after surgery in general. And so to take these normal activities back again is helpful. There's no real dietary restrictions after this surgery. I think it's very rare that you really need more than Tylenol for pain management. The other things like narcotics cause other problems and are often less helpful for the surgery. It does happen that some people have a more sensitive bladder than others, and so some people have a lot of spasms, irritation, and urgency to go to the washroom because essentially things are healing on the inside. That causes inflammation, which can cause some discomfort, some urgency. And so there's medication that can help with that, essentially relaxes the bladder. And it's very helpful often. So often we'll give a prescription for that with your discharge prescriptions. And overall, as you sort of might expect, any surgery has risks of bleeding and infection, this included. And so just staying well hydrated helps rinse things out and reduce infection risk, and also reduce if there's a bit of blood in the urine for that to get better. So that usually, the typical course, it's hard to say typical because there's always a variation, but some people have blood in their urine for 1 or 2 days at most usually, and it is healing, so you get a bit of burning BP, but it tends to get better really soon usually. So there's things like an infection. So that's just my fairly quick little blurb about the TURBT. I will not talk about mastectomy. Personally, don't do it because we divide our work, and that's not my division of work. And so I'll leave that to Sue. But go on with intravesical treatments. So BCG and chemotherapy are the mainstream. There's been some new things in terms of chemotherapy with the combination of 2 chemotherapies for not everybody, but for specific patients. And I'll talk about that. BCG has a very long backstory. For those of you who like backstories, it actually dates to a German physician who discovered what causes tuberculosis. And this was back in the 1800s. And back then, tuberculosis killed a lot of people. And so he discovered what causes it, and then they discovered a way of making vaccines by, we call it attenuating or weakening the bacteria, the mycobacterium that causes tuberculosis. And that's what some French scientists did in Ville in 1908. They took mycobacterium that came from the milk of a cow. It was very weak, and so you could actually give it to people without causing tuberculosis. And in the lab, they actually took them many years, turned it over so that it became a weaker and weaker bacteria, so that we could give it to someone that won't get tuberculosis, but they will get immunity to tuberculosis. And so that is actually the strain that we use for BCG. It's from the Mycobacterium bovis, and it comes from the lab in the Institut Pasteur in France. And that's where the name comes from. Invasive Bladder is the 2 people who were responsible for making the vaccine, essentially. And so this is I'm not sure about this, but I think it's the most widely used vaccine in the history of the world. We've given 4 billion vaccinations. We don't give it anymore in Canada, you probably might know. But it's a vaccine that was given cutaneously. And so what's interesting being a Canadian scientist myself is, and I've met Dr. Morales, who did medical school there, is that the use of this vaccine in bladder cancer is now almost 50 years ago. I think it was 50 years ago this year, actually. And he tried this out, and lo and behold, it worked. And for us to do research, 20 patients is not a lot for our studies, but he got it published, and it turned out to be the treatment that we still use 50 years later, not substantially different. So great work that he did, and great advance for patients. This is what we use now. So it's an attenuated mycobacterium. There's some sort of molecular biology that they've done to it to make sure that it doesn't give tuberculosis type things to people. That rarely can happen. And it works essentially as a immunotherapy. There's been a lot of vogue in medicine with immunotherapies now being used widely in the last 10 years. This predates that, and essentially, in a nutshell, now without going into all the details, stimulates our own immune systems to prevent the cancer from coming back. And so scientifically, it's very interesting how that works. And the bottom line is it works. When do we give it? Without going into all the indications, people who have high-grade non-muscle-invasive bladder cancer, and that's where the grading is important. If you have high grade, almost all patients will get it, barring a few reasons. Same with CIS, patients who have CIS, BCG is the best treatment if it can be given. It's not usually done for other reasons, but there are a few other reasons. But it's less common. And in terms of what does it do for patients, how does it help? Well, it reduces the chance of it coming back. Well, that's important, but that's not the only thing that's important. What's also very important is that when it comes back, it doesn't come back in the worst way. That is to say that it comes back and it's invaded more of the bladder. And it's the only treatment to date that has been shown to decrease the chance that it comes back in a worse way, what we call progression. And so this is, of course, a relative reduction. So it doesn't stop it from coming back, but it decreases the risk. And so it's a big improvement, but nonetheless, there's much work and research to be done because it still recurs in perhaps 25 to 35% of patients. And so I'm involved in research in that area. We'll mention at the end briefly. How is BCG given? So it's given in the bladder. And we do that with catheters, where you put a catheter in the bladder, fill up the bladder, and about an hour later or so, we empty the bladder. And just that contact over an hour stimulates our immune system to attack cancer if it comes back. So it is a bacteria. And so while it's weakened, there is still a chance. It's low, but there's still a chance that can cause an infection. And so we do have to take precautions, whether it's bleach after the toilet for sort of 6 hours, good hygiene, first for 24 hours from then. These are all things that sort of, why? Because it's a bacteria, and in theory it's infectious, although it's low infectious risk. It is an infectious risk, so precautions are important. How do we give it? So if you've ever been prescribed BCG or know someone that has, they will get it once a week for 6 weeks at the beginning. This is sort of what we term induction in the industry. That is, it induces the immune system, and so we started out at 6 weeks. And then we call it maintenance treatments. These are treatments that are given intervals after not 6 weeks of treatment, but just 3 weeks of treatment, and more or less every 6 months up to 3 years. Sometimes we give it up to a year. There's something else we call reinduction. This is, as the name might imply, repeating induction for another 6 weeks. So once a week for 6 weeks. Again, it takes about an hour treatment each time or so. So why do we give it 6 weeks? There's different answers of this. One of them is the scientific answer. That is that your immune system, the way it works, it takes about 3 to 6 weeks for it to really mount or develop the optimal response. The other reason is that it causes irritation. Inflammation is irritating, and this tends to settle down in cases, but it tends to settle down after a week or so. So it gives you some time between treatments. One of the other answers is because when Dr. Morales ordered his BCG from Canadian Laboratories, it came in a box of 6, so it was 6. That's true. And we've actually tried to do studies where we're seeing this 3 just as good as 6, but unfortunately we didn't get enough patients. These are international studies, and so we don't know if 3 is as good as 6 at this point. So so we do change this sometimes, and sometimes you have to postpone the last dose, and we don't get all 6 in a row. Again, it depends on symptoms, infections, there's a lot of blood in the air. There are reasons that we postpone the treatment on occasion, not that rarely. And obviously, whether we give it again depends in the follow-up, whether we see any recurrence of tumors. As I think most of you probably know, the follow-up is done with the cystoscopy, where we look at different intervals into the bladder to see if there's any recurrences. This is the best test to to detect recurrences. And then for some patients, we don't need to give all 3 years of maintenance treatment. 1 year is enough. And then one of the other complicating factors is in the past we've had problems with BCG shortage. So it's just a picture of a BCG treatment unit at the CHU de Quebec in the new hospital. Typically, nurses will verify that you're okay, you're not having fevers, you're not having infections, there's not a large amount of blood in the urine. And then they'll put in a bladder catheter, fill the bladder, as I mentioned, 1 hour, and then empty the bladder. So that's how it works. It runs pretty smoothly in most cases. There are problems, of course, that can happen. This includes burning, urinary frequency. I mentioned some of these, fatigue, some blood in the urine. And so this also does tend to get a bit more over time, not for everyone, but certainly for some people, the 5th treatment is a lot worse than the 1st. It's just a cumulative effect. But it's too bad we have to stop this sometimes. There are complications. I won't go into this too much, but the most common is getting a urinary tract infection. Put a catheter in the bladder, that involves a risk of infection. The inflammation sometimes doesn't help, and you can get a bacterial infection, not usually with the BCG, in fact. It's just treated with antibiotics. If it's bad, there is called BCGosis. So Dr. Morales did a lot of good for patients in inventing BCG, but he is also a person who invented disease in a sense, because this is a very rare disease where you get infection with the BCG vaccine in the blood, and sometimes it requires anti-tuberculous treatments to treat it. I've seen it maybe 3 times in my career. It's pretty rare. So how to minimize, from your point of view, the risk of complications or symptoms. And so part of the things is that the doctor will do an analysis before giving the BCG, just to check that the urine's okay. If things are not well, to wait a week is not the end of the world. It's a wise thing to do often. So being hydrated, urinating regularly, not holding the urine in the bladder for a very, very long time. These are all things just to help rinse out the bladder, essentially. And in some cases, I'll give the patients an antibiotic if they have a lot of problems after the BCG treatment. That's an option. So BCG shortage, I mentioned earlier. The reason for this is math. As those of you who are good at math, the BCG vaccine uses 0.1 milligrams of BCG. That's what you inject in someone. And when we put it in your bladder, we use 50 milligrams, so it's 500 times. So basically what you get in 6 treatments could vaccinate 3,000 people against TB. And so it's a lot. And so that's why it's hard to make a lot. And the stocks have fluctuated a bit. So it is a lot. I won't go into this too much, but there are different strains, like like COVID. I think you all know about COVID, and there's different strains of COVID you've heard in the news, undoubtedly. Well, there's the same thing with BCG. There's different strains, and they come from different historical places that made them. Whether they make any difference is not fully known. It's quite possible that they are different a little bit, and there's studies to come. Right now, there's only 2 approved. One of them is conditionally approved, but 2 approved strains in Canada: BCG Tice and Verity strain. And so, whether it makes a difference or not, I don't think anybody knows for sure. But we're looking into it. So, I want to move on to intravesical chemotherapy. This is the same idea as BCG. We put it in the bladder, but it's not the same in the sense that it's more of it's an anti-proliferative, or a drug that stops rapidly proliferating cells from proliferating. So if there are floating cancer cells, for example, after your surgery, that's possible. They could be there, maybe not. But it is shown that giving chemotherapy right after the surgery in certain cases is helpful to reduce recurrences. In the same way, giving it at intervals, whether it's 6 weekly, whether it's once weekly, may also reduce the risk of recurrences. And this has been shown, and this is essentially how it works, and it does work. And not for everybody, but it does reduce the risk of recurrences. It doesn't reduce the risk of progression, as I mentioned, the risk of becoming something more aggressive, which is why most of us in Canada, to get rid of BCG for that reason. but it is an option in certain cases. Again, we fill the bladder, the drug goes in, drains out, and that's it. It's not like chemotherapy in the sense that if you lose your hair, you nausea, vomiting, because it's only in the bladder, which is a big advantage for us as urologists. Now, you don't get all these side effects of systemic chemotherapy or chemotherapy that's given in the bloodstream, so it only affects the bladder. So it's very tolerable, generally speaking. This is the science for those of you who know anything about molecular biology. It stops these medications, more or less all stop the proliferation of your DNA. It works in slightly different ways, but these are the scientific names for them. There is a new combination which is of interest. This has not been vigorously proven, so it's not actually Health Canada approved, if you will. These are drugs that we use for other reasons, but it is a treatment that's quite inexpensive, and actually in many retrospective studies, I would say studies that were looking back at how they used it in Wisconsin, for example, New York City, they found that it actually works quite well. And so I know in the CHU de Quebec we use it. I know that Dr. Students in Montreal, and I think a lot of places do, not every place, because the data looks interesting. And so what it is we give one chemotherapy for 90 minutes, followed by another one for 120 minutes, 2 hours. This is not for everybody. This is for people that tend to have multiple recurrences, but it does tend to prevent more recurrences, and the preliminary results are quite interesting. But it's not like officially approved in the sense that the large studies to prove it works are not done. But it certainly has potential, and there are actually a comparison study comparing this and BCG, which is underway in the US. So that may change practice in the future. Where are we at in terms of treatments in the bladder that are under development? So these are not things that your urologist is going to offer to you tomorrow, but these are treatments that are on the way. There's actually two treatments that undergo what we call FDA. You might have heard of the Federal Drug Administration in the US. So they're the ones that evaluate whether a drug can be used or not. They're very stringent, and they have a lot of rules. And so they've actually approved 2 drugs for bladder cancer, but neither of these drugs are available in Canada at all. But I'll talk about them, because if the companies do get approvals in Canada, then maybe something that will be offered. And I just want to give a taste of, because I'm a researcher, of some of the stuff that's coming down the pipeline. I'm sure not all of these will make it to the clinic, but it does show you that there's a lot going on this invasive bladder cancer currently. So the first story, I cut off his head there, but Colin Denny is actually Canadian from Winnipeg, who's in Houston. And for the last 20, 30 years, how long it took him to work in his lab to develop this. But he developed a treatment where we put a virus. Now, viruses are bad, yes, but there's a lot of viruses that we have in the body that are not bad either. So he genetically engineered a virus that's not going to make you sick, but a virus that by putting it directly in the bladder will do something similar to BCG in the sense that it stimulates your immune system to attack any cancer cells that may come back. And so this, as I say, took decades of work. It actually is very well tolerated. That you just put it in the bladder every 3 months, and it decreases the recurrence rates. And so that was tested, particularly among patients who had recurrences despite having BCG. But for various reasons, production, development, and pharmaceuticals, it's not available actually in the US either, even though it is approved. But that may be down the line, we get more funding, perhaps. This is the science. Basically, it's a virus genetically engineered so that it doesn't make you sick, but it does stimulate the immune system in the bladder. The other one is actually a treatment which you may have heard of if you've had friends or family who've been treated with immunotherapy, because pembrolizumab, which is, I think, I have no financial relationship with them, but it's made by Merck, I believe, and it's a medication that stimulates the immune system against cancer. And it's not specific just to bladder cancer. It's actually used in many cancers. It's one of the first new drugs over the last 10 years, the sort of new wave of immunotherapy. The way it works in layman's terms is that our immune system wants to attack cancer. This is what it does. It's part of the normal function of our immune system is to prevent cancers. Now, the immune system is not perfect. It doesn't work fully. And in fact, the cancers sometimes trick the immune system by making it sort of slow down so that it doesn't attack the way that we would otherwise like it to. And this essentially removes those brakes that the tumor induces in the immune system so that it keeps attacking nonetheless. And it works. It's not perfect, but it does help many patients. And so they tried this out in non-muscle invasive bladder cancer, particularly for patients who don't respond to BCG. And indeed, it does work. So, about 5 minutes. 10 minutes, okay. So this is the science. The molecule that it blocks is we call an antibody. It blocks something called the interaction between PD-1 and PD-L1. So for a brief biology lesson, tumor cells have what we call antigens on them. These are unique proteins that identify a tumor cell. And our immune system recognizes that. It recognizes it's not part of us. So it attaches, and by doing so, it starts to coordinate other cells to attack the tumor cells. But when you have that PD-1, PD-L1 signaling on the side, bottom, that kind of signals the immune system, no, hold on, don't attack. And so then it stops coordinating the other cells to attack the tumor cell. But by blocking that signaling, the signaling to attack continues, if you will. So it removes the brakes and just keeps going, attacking the tumor cells. So it works. It has side effects, of course, because it alters with our immune system. Overall, the response rates are, these are patients who have not responded to BCG, so they're already sort of more at risk of recurrences. And the CR rate, which is the complete response rate at different time points there, 3 and 12 months, it's not fabulous. It's in the ballpark of 20%. So that's 20% of patients who have a good response, but that leaves a large number. So there's definitely room for improvements. And these are some of the other treatments which are being done. I think we have a study looking at this. This is a pretzel looks like, but this is the pretzel that gets put in your bladder, which is kind of surprising, but it works. Patients don't actually sense it that much. It stays for about 3 weeks. We have to go in with a cystoscope and take it out 3 weeks later, then take it out. So it's a bit more involved that way. And what the company has done is they've loaded this pretzel with a type of chemotherapy, a drug that attacks cancer. And this is very preliminary. This is not in use, but that we're doing the trials. And what the idea is that by putting the chemotherapy in a sort of a slow release formula, if you will, a slow release of drug over 3 weeks, instead of just a 1-shot, 1-hour drug, the tumor is exposed to more drug over time. So it makes sense. And in fact, it really is exposed to some of the preliminary science to a lot more drug than it otherwise would be. And it seems that this may work. We don't know. We're doing the trials, but this is sort of something coming down the pipeline, as we say, that may be of interest. And this has obvious applications because if it's non-invasive, then you can have diffusion of the drug, treat the tumor very well, and it may help recurrences as well. Now, the story is not finished for that, but it's still underway. And so this is what it is. It's called TAR-200. That contains chemotherapy. There's a new version, which is called TAR-210. This contains another more fancy drug, if you will, very expensive, in fact, which is a molecular targeted drug against certain kinds of cancers. So that would be story is not finished, but is something that's in the works and may have a role in the future if the studies pan out. Other acronyms, lots of acronyms, but it's the UGN 102. I have no idea what that acronym stands for, but this is their second drug, I presume. They did another drug for upper tract urothelial carcinoma, which I'll talk about, but this is a study that was published this year, or last year, I think. And they evaluated, instead of putting a chemotherapy solution into the bladder, why don't we put it in a gel? And so a gel, what it is actually, it's very interesting science. It's a fluid that you put in, and then because the body's warmer, the temperature chemistry makes it solidify. And so then it stays in contact a bit longer because you have this basically jelly in your bladder. And over the space of 24 or 18 hours or something, the urine washes it out and goes. So it involves a bit more, again, exposure to the chemotherapy. And the results, were basically nothing that's going to be used tomorrow in the clinic, but there was some good responses, and certainly there are more trials ongoing. But of course, they made a newer version, so they have to use the newer version. It takes time to figure this out. So it's not ready tomorrow, but it's perhaps on its way, or similar versions of that. This is a company contacted me a couple of weeks, but we have other trials. So we're not doing this trial, but it's essentially, again, a virus. And all viruses are not bad, and in the sense that we always have viruses around us. And so they use a specific virus that does not make us sick. And they, again, use some genetic engineering to change it around. They put a bunch of interesting factors for the immune system in the virus and coded in the virus so that when the virus goes in your bladder, it will essentially direct your bladder immune system to attack the cancer. Sort of the same theme, but just a different engineering technique. And we'll see. The studies are not fully done, but it's an interesting concept that makes a lot of sense. It's somewhat similar to the other one that didn't get invented. This is a drug. It's a mouthful to pronounce, as many of them are, which is actually used and very recently been shown to be very effective in metastatic urothelial cancer. I put this slide in here because there are studies looking at this in non-muscle-invasive bladder cancer. This is we call a monoclonal antibody, which is a protein resembling some of our proteins, but again, it's targeted against a certain cancer protein. So by doing so, this protein or monoclonal antibody, when it goes around in your bloodstream, it finds the cancer cell and attaches to it. And the trick that they did, sort of Trojan horse trick here, is that it brings along with it a payload, as we call it, chemotherapy with it. So it sort of hones to the tumor cell, and then behold, you got chemotherapy beside it. The chemotherapy will destroy the tumor. It makes a lot of intuitive sense. Of course, there's a lot more detail than that to make it work, but it does work. And they're trying the same thing in non-muscle invasive bladder cancer. We have this drug. The pharma companies say, why don't we try it by putting it directly in the bladder to see if it works? And it might work. But it's very interesting to see. Of course, the cost is an issue with these monoclonal antibodies because they're frankly very expensive. And so, but certainly more to be seen on that. And there are trials under that. Conflict of interest here. I am doing this trial here. And so our lab has looked a bit at something called the androgen receptor. It's a protein that's treating prostate cancer, and it's very important prostate cancer, but it actually is in bladder tumors as well. Perhaps 50 to 60% of bladder tumors express what we call the androgen receptor. And our work in our lab and a lot of retrospective study looking at drugs that alter hormones, because the androgen receptor is for the testosterone and hormones. It suggests, in fact, that patients who have received these drugs have better bladder cancer outcomes. And it's quite impressive, some of the data. And so with our lab work and putting together a good story, we got some money to look at this. And the study that we are currently doing, this study is actually open at Quebec City at my site. It's also open with Dr. Kassouf at McGill and the CHUM as well with Jean-Baptiste Latour. And what we plan to do here is to see if we can improve BCG. So it's been a while since it's been approved, but we think that by adding bicalutamide, which is a drug already used to treat prostate cancer, it's fairly well tolerated. People do get some enlargement of the breasts. It causes a lot of, I should say, it's only used in prostate cancer, so we have no data in women, which is one of the reasons why we're doing this study only in men. But we give this drug for 90 days at the same time we get BCG, and then we compare it to the other half who are randomly assigned to the normal standard of care, BCG. And what we want to see is if it reduces recurrences of bladder cancer, as you know, recurrences still happen in 30 to 40% of patients. And so this study is underway. And then, of course, we're going to do some science looking at tumors and sex steroids, things like that. So that's another thing in the pipeline. It's called the BKFACA study branch, and it's for men who are starting induction BCG, and we want to see if it decreases the rate of recurrence. So we'll see. And we'll finish with this slide here. My apologies, I made the slide in French originally, but yes, it's Quebec Health Research site. I'm sure if you Google this, it'll be there. But there's other sites as well that were mentioned. But this is where you can go for the province of Quebec, and you can see what trials are available if you're interested in those things. So, spoke a bit about surgery, but mostly about BCG and chemotherapy. These are treatments that have been known for decades. They decrease the recurrences of bladder cancer. Like giving it directly to the bladder, it works well, and there are new treatments underway. And with that, I will finish up and take questions that you may have.